everyone. Welcome to Public Health Musings. I'm your host, Dr. Caroline Kingori, a public health researcher and a faculty at Ohio University. I'm so happy you could join us today. This is the second show with YouTube, and I'm so excited to have launched this show on YouTube. So if you're listening to me from Apple Podcasts or Google Podcasts or any of the other podcast platforms, I also encourage you to go on YouTube, Public Health Musings, subscribe to all these platforms, and share with your friends and your loved ones. And let's know more about public health. So today I'm excited to speak with a young lady that I just met the other day. She contacted me on LinkedIn and trying to find someone who can mentor her in this field of public health. And I was more than excited to work with her. And we are already working on a book chapter. And we have some other ideas that we'll get into as we continue collaborating on various public health projects. So please join me in welcoming Kobi Ajayi. And she is currently a PhD student, and I want her to tell us about herself, and so that I don't have to speak for her. But I'm really happy to know her and her journey and the work that she's doing that's impactful. She'll tell us a little bit about the work that she's doing here in the US. But just give us an overview of who she is. So welcome to the show, Kobi. If you could just start us off with telling us a little bit about yourself, and then we'll get into the journey of how you got here. So, just a little bit bio of who you are.
Hi, thank you, Dr. Kingori. It's an amazing opportunity to be here today. I am so happy to speak with you and to get to know you. And hi, everyone. Like Dr. Kingori mentioned, my name is Kobi Ajayi, and the V is actually Vanessa. I am from Nigeria, and I'm currently pursuing my PhD in health education at Texas A&M University at College Station here in Texas. I am a mom. I like to first identify myself as a mom because I believe that was what gave me my life's purpose. Like immediately I became a mother. So I'm a mom of two very, very active girls. They are 4 and 3, but somewhere in my head, they are 15 and 20. Don't ask me how. So I do a lot of, I love volunteering. I love working. That's not so much of fun, but yeah, I love it. I love hanging out playing with my daughters. I actually relate with my daughters more like we're mates, and it gives me so much fun. I like when we have conversations, I have to explain things to them. For me, I think my grounding philosophy is based on my faith. I would always talk about my faith as what leads me to doing anything I do, which is my going into my research, my foundation, and all the very fun things that we'll talk about later on in the program. So that's a brief overview. I'm trying to keep it very brief.
Thank you so much, Kobi. So we'll just jump right into your journey. And you told us you are currently pursuing a PhD, and I just want everyone to know, you gave us a little bit about yourself, but also just tell them that your research is more on the behavioral and social cultural factors, and we'll talk more a little bit about that as we get into the show. But you're now pursuing this PhD in community health evaluation and systems science, and tell us what that entails. What's system science? I'm familiar with community health. That's what I teach. I'm familiar with evaluation, but tell us a little bit more about this focus on system science.
Okay, thank you very much. Before I go in, I would like to make a little bit of clarification. I work in the lab of the system science because my PI, she is heavy on systems method. The whole idea about diving into what systems science is the idea that nothing happened in isolation. So if we use the social ecological model, which is we usually work with the McLeroy, the 19, I don't want to mix the year, but the McLeroy model of the social ecological model that has 5 factors that looks at the individual, the interpersonal, the community, organization, and public policy level. So essentially, elements within these systems all interact with one another to either affect health outcomes or whatever health outcomes we're looking at. So when you're designing interventions or designing programs or even making public policy, we need to be aware of the interacting factors that causes other parts of the system to either malfunction or become function optimally. So the whole idea of system science is looking at public health in a broad perspective to understand that it's a system. In as we can't treat issues, we can't treat diseases based off on the symptoms only. We have to look backward. We have to say, okay, what happened to this person? What's the person's growing up like? Where did the person grow up in the first place? How what's the person's cultural belief about XYZ disease? So those are the factors that we all have to take into consideration when we try to create informed public health efforts. So that's the whole idea about the systems science.
Awesome. That was a really great explanation. And typically in this podcast, my whole purpose is to show people just that systematic way of looking at health issues and not just seeing that, oh, there's this one individual. Why don't you eat healthy? Why you're not exercising? There's so many other factors in the environment that are influencing their health outcomes. And so it's important to sort of take away that burden of change on the individual and to constantly blame the individual for not, being proactive about the changes. There's so many other things outside of their control that may be impacting their health behaviors. So thank you for that. But I know that you have an MBA and then now you're pursuing public health. Tell us how you got to this point, why that shift, and is the MBA helping you? Do you see ways to link, systematic way of linking what you did in your MBA? Because now you have an MPH and you're pursuing this public health degree.
Thank you very much. So I would say public health, MBA are all interconnected. But like you said, just to give you a bit of background as to why I did an MBA first was growing up in Nigeria. I had worked in a firm that my first exposure to corporate industry, I didn't like what I saw. And I felt there was need for structure. I felt it was like a burden on me. I felt I needed to be in that position of leadership. I saw so many loopholes in the system that I knew that I would love to work in this capacity. That was what broadly informed my decision to pursue an MBA. However, again, it's funny. I don't know. I don't want to use the word funny. I've always loved to help. That has been my driving force to wanting to do anything. Even the work I do, it's always the first point of contact is I want to help, or how do I help? So it's this whole process of wanting to help. I moved up in my ranks. I got a new job while I was back in Nigeria, and I was working as a communication manager in a corporate industry. But I had the opportunity to work with communities as I was responsible for the organization's corporate social responsibility. We were involved in drilling boreholes in rural communities that were targeted at women and girls. At that point in time, I was just a new mom, newly wedded, new mom. That was some years ago. I didn't know so much about the maternal health system or even women's health. It wasn't a thing, like nothing. Until I started working in that capacity and I saw that what's going on here? Why are women going through this problem? Who did we offend? That's some kind of Nigerian joke things we say to like, why is the situation this bad? So that was when I realized that I needed to study an MPH. So I searched and searched. I figured out that I know I wasn't cut off for the medical field. but I needed to improve health in one way or the other. That's when I got to realize that, oh, there's something called public health. And marrying the public health and MBA, it's very, today we know that nonprofits are the bridge between the government and the private entities, in that they are able to help more people that the government that falls kind of away from the government or augment the government sector. So they're able to provide more services or additional services. So this is where my MBA comes in, because as someone in the MBA track or field with or knowledge, I need to know how to manage. I need to know how to allocate resources, and these are integral for in public health. Even in some days, some public health programs right now actually do have the MPH and MBA track combined, because there is need for it. You can't, public health can't just work in isolation. We need to manage, we need the resources. There's a lot of inflow and outflow of cash. There's a lot of human capacity that needs to be managed. So I see myself, I'm happy even that I got it. When I got it, I wasn't thinking of public health, but I'm really happy now. And even currently, I'm trying to get the nonprofit certification. This would now be particular to a nonprofit certification, because that is where I see myself, my public health manifesting in the future. Yeah.
That's awesome. And I definitely wish you the best, even as you try to get that certification, and as people will come to learn what you're planning to do in the future, and even the current things you're doing to sort of merge your work in MBA or what you learned, but also helping women with regard to maternal and child health. So tell us also, about your research interest. You're focusing on behavioral and social cultural factors, looking at women, children, as well as families, and you've been involved in other research projects on COVID immunization and access to healthcare work. So I want to talk a little bit about this focus on women, children, and families. Could you tell us what your motivation is related to that research? I mean, you talked about being a mom, but how did you translate that experience into wanting to now focus your research trajectory on that?
If I want to go into this topic, we might spend the whole day. So I'll try my best to make it really short. The whole idea, like I mentioned earlier, my overall goal, I always say that, I'm sure, and I'm saying it again, I found my life purpose after I became a mother, because I saw other women and other families going through so much hardship, all because of they gave birth. And I saw other women more like women tend to lose themselves, or the main existence of themselves, their main core, because they became either wives or became mothers. And it's really painful to see that I read, let me digress a bit. I read somewhere, and the lady made mention of, why are we not hearing something like house husband, right? So if you say I'm a housewife, why use the word housewife? Why don't you just say I'm a wife? Why don't you just say I'm a housewife? Well, you don't use the word to say I'm a house husband. I would like to put it out there that I'm a lover of both men and women, or genders or sexes attaining their fullest potential. But the societal belief or restrictions on women, it's so painful and harmful that we tend to forget that we're humans first before our genders, and we should have equal opportunities to whatever thing we want to do, and we should dream as much as we want to. So as such, I see myself mainly as a behavioral scientist. That's what I call myself, a scientist, behavioral scientist, because I try to understand how our experiences, where we live, how we live, and the people around us, like I mentioned before, the environment and all the ecological factors that affect our health outcomes, and how can we inform create programs or policies that can inform those interventions to meet our specific need. I'm really heavy on culturally responsive programs because I believe that we're all unique and we should attend to our unique needs in unique, not just in a blanket situation, like provide a blanket policy or blanket program for every woman. Every woman is different. So those are the things that I look into. And as to whether or not you talked about COVID, I'm doing research on COVID-19 and immunization. The truth is, we can't isolate those experiences. When you have something like, we need to understand, for instance, there's a surge of COVID-19, or rather, not just COVID-19, vaccination hesitancy, right? We need to understand, why do people think, or why do people not want to vaccine? What are the root causes to vaccine hesitancy? How do we address those things? So those are the cultural part, those are the behavioral part, those are the societal part of it that we need to all look into. So I wouldn't really say it's separate. I would say it's just broad, because when it comes to behavior predicts so many things. Like, we can't rely only on the medical model to create interventions or programs. Rather, we need to look at the behavioral side of it and the societal side. So they all are interconnected. Yeah.
I definitely concur with that. And also with your work with access to healthcare, what would you want to tell us about that, and your interests in that, in addition to the COVID and immunization work?
Thank you so much. So access to healthcare, we all know that access to healthcare, we can use the blanket term and say access to healthcare. It might mean anything. And in the US, access to healthcare might mean transportation costs, might mean that transportation barriers, might mean even for a mother, it might mean daycare costs, trying to figure out how to care for where to keep your child while you go to the hospital. Or in Nigeria, where I'm back from, health access might mean not even having a healthcare provider in the first place. So I like to see access to healthcare as contextual, based on the environment where, how do we define it? Based on the environment where we're talking about a particular environment. So again, I'm in tune towards women and women, mothers. Access to healthcare, let's use the regular antenatal care visit, for instance. A woman that doesn't have the right access that doesn't seek antenatal care, what are the barriers? For instance, there are a lot of studies out there I'm using Nigeria as a context right now, that issues pertaining to respect, there's a lot of issue with disrespect and abuse, how mothers go to the hospital and they're not respected, they are spoken to in ways that demeans them, and at the end of the day they don't want to go to the hospital again. There are issues about transportation again, and there are huge issues about availability of staff, of healthcare providers. Those are one of the barriers, or rather, those are part of the barriers that have been reported constantly in the literature. So, looking at it holistically, we can't isolate one from the other. So that's still if we educate mothers to say, okay, you know what, antenatal care is very important. Okay, there's an issue with barrier, maybe having to transportation issues, heading from one point of location to the other to head to a healthcare facility. What about if we use traditional birth attendants? What about if we empower traditional birth attendants or community health workers? How do we bridge that gap? How do we bring the service to you, right? So those are things in general that we need to look out. So in general, again, I'll say it's behavioral, because sometimes the services might be there and they won't still use it. So how do we sensitize the people to say, this is good, this is important? Because there's this, going back to my Nigerian society, there's this thing that is common, like, oh, my mother did it XYZ way, so why should I? She didn't die, so why would I die? So it's educating women continuously and constantly of the benefits of these services as well, right? So that's important. So I think access to care it's important, even in the US. transportation barrier is a huge problem in the US, especially. We find in the literature has been reported over and over again, people who are far away from like rural communities or communities with lower socioeconomic status, they have issues with public transportation, and the time it takes before you have to go through hop into a bus and get to your doctor's appointment, you might have to take how many stops. Whereas if you had a private car, it might just be maybe a 5 minutes drive. So those are issues that again need to be addressed. And it's again, I'll go back to the system. It's a system we need to address. There's some issues that are systemic. Up there in policy level, there are some issues that are behavioral that we all need to work to address. Yeah.
That's a really good perspective. And as you are talking and discussing how access to healthcare is a systematic thing, because that's really what, as you have seen, what has impacted people getting access to testing for COVID-19, and also having people have access to immunization. And access is not just saying, hey guys, we have this test, we have, you can come here and get vaccinated. That's not enough. There's always a question of how, especially in communities that, where we find there's this association with some of the cultural beliefs, we have to understand where they're coming from. And right now, we know, as you have seen, COVID-19 continues to be, to be a problematic. We are getting a handle of it here in the US to a certain extent, but we still have some of those challenges with people accepting to get vaccinated, and without having to judge them. It's a thing of understanding why do they have these ideas associated with vaccinations. How can we engage them in a conversation? And same thing is happening in the continent as well. And I don't know if you have any information on how the vaccination drives are going on in Nigeria, and what are people saying, and what are some of the ways that people are being encouraged and rallied to get vaccinated when we think of that blanket of access to healthcare services.
Okay, when you talk about Nigeria, I'm only going to, what I'm saying right now is all anecdotal, because the things that people have said, my family members and all. First of all, as sad as it is, none of my family member is vaccinated, like none, zilch. That's because there's this whole religious polarization. It's now politically motivated, and it's expensive. It's not free. I think my husband is vaccinated, and the only reason he got vaccinated was because he was going to come to the US, right? And the reason he didn't want to get vaccinated was the whole issues, the misinformation around the vaccination causes XYZ and all that. So it feels like I'll be fine. I don't want any issue. And besides, there's a cost issue. So it's for countries in like Nigeria, it's especially other rural, or rather other developing nations, or rather the low and middle income countries. I think it's a huge problem because the disparities it's glaring. Vaccine access is a problem, and the issue now is, how do we encourage? We need to create. I think, for my own view, we need to create culturally sensitive messages. Right? We need to try to dispel the misinformation. And for me, one key area that I think we're missing out is religious folks. So in Africa as a whole, at least in Nigeria, we are very, very religious. The average Nigerian would listen to what a pastor or an imam tells him or her, but would not listen to what a friend or even a medical practitioner tells him or her, because they believe that it's divine intervention or divine knowledge from God. So how do we incorporate religious bodies into this drive to improving vaccine uptake? So I think that's a key strategy that it's proven that. I think, I'm not really sure about the statistics, but I know there was a time about some polio eradication that they did in the northern part of Nigeria, I think northeast. They actually included, with the whole, I think, WHO and the rest of the international non-profit organizations, they included religious folks that we're able to encourage people to take vaccines, the polio vaccines, because left to the average person, like I mentioned, they wouldn't listen, no matter how much you educate them that these are the consequences of not doing this or consequences of not getting vaccinated. It's just like, I haven't died, or it's just a hoax. It's not real. It's a planned thing, and the problem is, again, is there's this talk in Nigeria that goes like something like, it's not a poor man's disease, it's a rich man's disease. And majority, since the poverty rate in Nigeria is really high, from the last time I think from the World Bank, about the average Nigerian spends about $300 and something a year. Like, that's a year, meaning a day they spend about less than about $1.50 a day. That's how much they spend a day. So that's how much the poverty rate is really high. So things that are, in quotes, a rich man's disease, like, where will I go and see somebody that have coronavirus? Is a rich man's disease. So there are so many factors involved that we really need to, again, and the whole distribution channels globally and the supply chain that we all need to put into consideration, and the whole talk about decolonizing public health or decolonizing health in general. There's a quote, I can't get it verbatim, but there's a quote from the very popular president of Rwanda, Kagame, yeah. And when he said something about that, the Europe, which I will include the global north, shouldn't see aid as the one person is giving the other person, somebody is giving the lesser person some form of generosity. Is a collaboration, right? So, and Africans as a whole, we need to step up our game. We have the people, we have the human capacity. The government need to put out fundings for research. It's important that without research, we're not moving anywhere. If we don't invest in research, we're not moving anywhere. We're still going to continue being, in quote, slaves to the global north. So that's something that worries me a lot, because we're not spending enough money, or rather the government is not spending enough money. It's not allocating budgets into, like, real budget into health, which it's really important.
Yeah, I'm really glad you brought up some really key issues. When you talk about the budget, there was an agreement about the allocation for the national budget and how much would go to health. Right now, it's very little. It's probably at 5%, and I think the agreement was about between 15 and 20%. But as you can see, with all the other pressing issues, health and education always tend to be the last thing that most of these national governments think about. Look at the United States right now with the health system and the challenges that were brought out by COVID-19. And again, because of not enough focus being given to resources that can help ramp up and support the system. They also brought out issue with culture and religion. And those, again, are some of the things that we as public health practitioners don't really have a good handle on how to address them. And we often maybe gloss over them, or we don't want to think about them. But, when you talk about decolonizing public health, this is contextualizing those issues in these communities that are culturally driven. And I have a mentor, Dr. Collins Arirambua, who's also from Nigeria, and he created a Pen 3 model. And what he wanted was to sort of find a way to understand culture and the impact that it has in health behaviors and health decisions. And so this model has been very significant, not only in exploring how cultural contexts shape health beliefs and practices, but how family systems play a critical role in enabling or nurturing positive health behaviors, and trying to come from the frame or understanding of the community. It takes time. That's the other issue when we have to sort of have that community-based participatory research, but this is for the community. And unfortunately, as professionals, we are inundated with doing things within a certain period of time. Your funder may only give you money for 1 year and expect you to have everything done in that 1 year, especially if you're working with communities that, are not very used or are tired of being always researched on. And that can really impact our success in engaging the communities that we work with. In the US, they've been very successful with engaging faith-based organizations. And that's a model that we need to continue utilizing in communities in the continent, in Africa. But that I've also seen some grassroots organizations in the continent that have been very instrumental in working with those health beliefs, as opposed to saying, your thoughts are so backward. Why would you think like that? When we do that, we alienate the individual. And that's where we're seeing some of these things come up with the vaccine and testing for COVID. But if we find out why these thoughts, and when they say, well, no one else in my family has died, then you want to understand what that means. But again, it's always about time and our capacity to be empathetic and to want to engage with our communities. So I really appreciate that, you raised some of those key issues. So I know you are also interested in maternal mental health. Now, just think about mental health itself. And then now we have to consider maternal mental health. That's an area that you're really focused on. And I want to have an understanding of, what do we need to know about maternal mental health? You are sitting on the board right now for a nonprofit organization looking at this issue. We know mental health generally is not really well addressed globally. Tell us more about this maternal mental health.
Oof. Maternal mental health for me, it's personal, first of all. And the first thing I would say is you can't discuss maternal health without the other M, which is mental health. You can't. I don't agree to that. I don't subscribe to that. Because, first of all, a little bit of history, which we all know. Females are 2 to 3 times more likely to have depression than males. This is regardless of whether independent of childbirth. So independent of even being in the reproductive age, right? So women are prone to, because there are so many factors. Women's health is so unique, so broad that let's give a little brief example. Let's start with the early puberty stage, adolescence. There's the issue of the premenstrual syndrome. I might be getting that name wrong. From there, the young female adolescent moves and gets to reproductive age, and she starts giving birth, and there are changes, hormones fluctuating everywhere, and she moves and becomes premenopausal and becomes in the menopausal stage. Those are significant changes, variations to the whole system, to the whole human system. And this is aside from the cultural, societal problems or issues that women encounter. So I believe that if we don't address maternal mental health, then we're actually not ready to address maternal health in general. And sadly, there's been little talk about it. Luckily for the developed nations, there are a lot of work going on. And even recently, I think there's a just proposed the end of the year 2020 budget for the United States. I think there's a proposed budget for maternal mental health research, which is like a first time thing. It's really, really key. So that's to show that there's progress, there's talk about it. Recently, I watched a documentary on When the Bowl Breaks, a documentary about postpartum depression and psychosis. It was so painful to watch it that even some of the mothers in the video had actually had infanticide. And so many questions were coming up, like, how do we even incorporate, for instance, the criminal justice system? How do we not criminalize crimes stemming from mental health break, like a psychotic break? How do we not criminalize it? Because mothers still have to go through that whole process. Like a mother, there's an infanticide issue and she's judged not based on her psychosis, but based on the crime itself. So in the US, like I said, there is, or even in the developed nations, Canada and Europe, there are talks about it. But in my dear Africa, it's a problem, and I feel so pained. Recently, let me give you a story. Recently, I thought, oh, I want to do like a a scoping review of maternal mental health issues in Africa during the COVID-19. You wouldn't believe that in my search of the literature, I used all countries. Like I wanted to, it was so in-depth search strategy I used that at the end of the day, I only found two studies in the whole of Africa on maternal mental health. I felt I saw the studies and I was pained. I took it personal. I'm like, where African mothers, are we not humans? Like, did the COVID-19 not affect us? Mind you, there are large reports of increased suicide rates in South Africa. I think even in Nigeria and one other African country, I can't remember, since the COVID-19, like increased suicide rates. Maternal health has been impacted drastically in developed nations because we didn't have the technology in place to transition, right? Unlike the US, for instance. So why are we not looking at this issue in Nigeria, in Africa as a whole? The one study I saw in Ghana, it was, I hate to be the one to say a poor study, but the method is questionable because they weren't even validated screening tools that were used to screen mothers, right? It was only the other one used validated tool, and that was conducted in Ethiopia. So more and more needs to be done. Before I even go finish up to this question, something that came up while I was trying to conduct the systematic scoping review, I checked the African Union page. I said, okay, let me check their Facebook page. They must have said something about maternal mental health. In their talk about COVID-19, there are a few here and there stories about mental health, but no mention of maternal mental health. In the pamphlet of the African Union and the African CDC, they have this collaboration between both organizations. So there's a pamphlet on how to care for your mental health during the COVID-19. There is no one mention about pregnant people. There is only mention about vulnerable populations. So who are vulnerable populations? So you can actually define a vulnerable population, for instance, as maybe someone who is currently maybe ill or having a chronic condition, who already has we already know that people with chronic conditions, for instance, have higher chances of having poor mental health. So, but however, we can't, if we're going to create an intervention, if we're going to create a program for people, vulnerable populations, are we going to create one blanket program for all vulnerable populations? No, we can't. And there was no mention of pregnancy, no mention of maternal mental health. And I felt really pained. Like, who will tell them? Is it that they don't know? There's studies out there in the country or in the region that already says that African women experience depression, postpartum depression, and the rest, poor mental health, just as, and even if not more than developed nations. Because again, the mental health capacity in the region is really low. I can't remember the exact numbers, but I know that the number of mental health service utilization and providers in the region is really, really low compared to the global rate. So we need to work more. We need to know that mothers are experiencing higher rates of depression and anxiety, especially on the whole range of maternal mental health disorders. Yeah.
Nice. And I wanted to follow up on a paper that you presented at the American Public Health Association last year, when you looked at the age differences in the association between pregnancy and depression among the US reproductive age women. So, with your findings, you talked about younger pregnant women are more likely to suffer depression, and it's important to enhance screening and diagnosis in this population. What else would you like us to know about that trend for prenatal depression?
Thank you. Prenatal depression now, are you referring to by age or in general? Okay, so
yeah,
okay, great. By age is important because depression for adolescents, there's the issue of it's younger age women face some very they're stigmatized, first of all, for being pregnant young. So as a young lady, you're pregnant, and they have higher rates of or higher rates of stigmatization, the social how what's the word? I'm looking for a word. There's this
Social
castigation.
exclusion. Yeah,
Exactly.
social
Yeah, you're right,
exclusion.
right? That it's already there because they're pregnant. And it feels like they're not going through the norm. They're not going through the norm that is expected by, again, society, right? But there is something that is interesting here that we need to really be informed about. It's not just, aside from my findings, it's not just looking at it in the broad aspect of it. If you look at, if we break it down into racial and ethnic groups, right? Not in the United States, non-Hispanic whites, for instance, they are more likely to be in a good school zone and with have the services to attend to their needs, or even not just services, they have parents or family members who can afford, even when they can still continue going to school and still be able to have their child, right? So it doesn't necessarily mean that the black adolescent or young girl is having higher rates of having babies or teenage pregnancies more than their racial counterparts. It just is the services that are out there to aid these people. So what we see is what is reported, and what is reported is that African Americans or blacks, or rather, let me use the broad term, women of color, tend to be dropouts. That's what we know. Women of color are dropouts, or women of color they don't do XYZ. The truth is, again, going back to the system, there are systems in place for one particular group of people that they are able to manage or mitigate the consequences of whatever action they have has happened. Whereas another group of people go through the same process and they don't have that safety net to help them manage their situation. So they just go down the cracks. They just go down and down. So when we report it when the report is out, what we see is that outcome. So how might we help, or how might we inform both places? How might we make sure that regardless of life that happens, I always use the word life happens. We might have all laid out, I want to do X, Y, Z, and life will happen. And you see yourself starting with Z, Y, X. I always say life happens. What safety nets have we placed so that people who would normally, when they fall down, would have more help to rise up, right? For instance, women of color, you have them. There's the word called adulting. You see a teenager taking care of a number of younger ones, and before you know it, that teenager grows up with higher rates of anxiety because they have this pressure on them already to perform. Whereas, or because of, again, why do they have that kind of, why are they in that situation? Their family members or the adults who is taking care of them, they're working odd jobs. They're doing like 3, 4 jobs just to get by, right? There was a before and there was a news, something that went viral last year about how police they arrested a young lady who left her 2 daughters at a motel because she had to go work. So someone, I saw one it was, I love how the whole everybody saw it and they knew that the system is wrong here. I don't want to say the system is wrong, but there's something that should be done in this kind of situation. What do you
Yeah.
want the young single mother to do?
Yeah. Yeah.
Sit at
I think
home?
even the judge did say that the whole issue was not handled correctly. She could have received counseling, but the children should not have been taken away from her, and also she should have been taken to jail, because now the children are put in the system, and it's a system that's already inundated, with so many other needs for children when you think about children's services. So The system, you're right, the system does have some cracks, and it has contributed to some of these health disparities that you're trying to highlight. And I wanted to sort of get into the segue of, because of so much interest that you have in this topic of maternal health and children and families, you form an organization called Eden Foundation. So tell us more about that, even as we start winding down in the show.
Oh, Eden Foundation is my baby, my other baby. So I am a preemie mom. That is, I have a daughter who was born at 33 weeks in Nigeria. That experience, I before I had her, again, I was already a mother. I went through the postpartum blues that I cried for a couple of days. I felt like society cheated me of not, and not just society, my family, even the hospital system cheated me for not preparing me to say, hey, when you become a mother, you lose your life. Kind of like you can't sleep, you are waking up, you're like somebody else is controlling what you're doing, right? And I was able to get a hang of it with time for my first pregnancy. And for my second pregnancy, I never knew. Before then, I had these are personal things for me. I've had miscarriages, but again, I was not even educated before getting married, before having pregnancy, before even having the miscarriages. I had zero education about these kind of conditions. So when I had a sudden preterm birth, I had a sudden preterm birth. I had just imagine from full pregnancy, full healthy pregnancy to having a full placenta previa, from having a full placenta previa to having, to I eventually had a PROM, which is premature rupture of membrane, which my daughter ended up coming at 33 weeks. It was the hardest thing in my life that I've had to go through. That first 1 year, I don't know how I went through it, but it was the hardest part of my life. While I was at the hospital, I had some little things. I had a breast pump, something that's supposed to be normal, right? And while I was at the hospital, the other ladies, the other mothers that were there that had children at the neonatal intensive care unit, I would see them sitting out. And again, we're in Nigeria. We were all sitting on the floor. I was lucky enough, I had resources to afford some convenience. So I'll go home, extract at home, drive back, because I had those resources. I was fortunate and blessed. But the other women at the NICU, they don't have that. They didn't have it. So they sat on the floor at the door of the NICU, mosquito bites on them. These are women who just gave birth through like traumatic birth experience, having a preterm birth. And they're sitting down by the door, hand pressing the milk to come out because they have to breastfeed their baby. And for some reason, the hospital, the nurses are refusing to allow formula, even when the mothers are not lactating. So that whole experience coming back home, trying to care for my baby, that was what really changed my life completely. Because even prior to that time, I really didn't know about mental health, nothing. Not to talk about maternal mental health, until I saw myself going down and down. And I knew something was wrong with me, because before then I always used to pride myself. I'm very strong. I have experienced so much, some very not fun things growing up. So I used to say myself as strong. Nothing can shake me anymore. But this was my breaking point. So I knew I needed help. And after that experience, I couldn't get over the experience. I was like, there are other women like me. I mustn't be the only one. So that was what really informed my decision to start the organization as a whole. Like, how do I, again, back to that, my whole mentality of I want to help. So how do I help these people? This is something personal to me. And coming out and seeing the data out there, Sub-Saharan Africa and South Asia have the highest rate of preterm birth. And I'm like, why? I'm tired of this narrative. What can I do? So it's no longer personal anymore, like, oh, I experienced it, but I'm seeing other people like, oh, there are other women like me. How can I help in this situation? Because we need to do something. We need to improve in what area or the other. So that was when I started looking at how do I help? How do I come in? because I believe that in life, every stage we pass through in life, there's a purpose why we are there. And if there's a purpose we are there, it's because we are there to either learn to become stronger people or to help the next person behind you who's going to go through that situation. So that was where my whole mission of Eden started. And Eden, the name Eden, it's an acronym, a very long acronym: education, direction, EDE, empowerment and nurturing. Because I wanted the term Eden, again, back to my philosophy, my foundation being a Christian, I wanted that garden of Eden, the whole idea of bringing bliss back, right? So in a nutshell, what we do is we created a kit based from the WHO and UNICEF Survive and Thrive report that looked at caring for small and sick newborns in strategic areas, which includes primary, tertiary, and secondary levels. So those are things like providing medications for infections, providing thermal care, education, lactation resources. So that was where we came in. With since the public health in me and the researcher in me want something that is evidence-based, and I went for something that has been proven that this, if you target interventions at this point, you're able to save more lives. So that was where, so what we do is we have our kit that contains a breast pump, it contains a warm blanket, it contains antiseptics, which for infection. So they're all meeting strategic needs, and we hand them over to mothers of preterm babies at the neonatal intensive care unit in rural hospital or public hospitals in Nigeria. The goal is sub-Saharan Africa, but we're starting with Nigeria. And again, my mental health cannot be away from it. Like I said, you can't talk about maternal health without the M, which is the mental health. So we created a pamphlet for now, because that'll be the first stage of it. We created a pamphlet where every mother, we're starting with one hospital, a public hospital, a national public hospital in Abuja. Every mother that goes through an antenatal care visit should have one pamphlet to educate them about maternal mental health. If you don't know what you have, it's more of a problem. Ignorance is more of a disease than the disease itself. So every mother that goes through antenatal care should be educated on maternal mental health. So that's where we are for now. But eventually, we would look at training healthcare providers like nurses, so that they can as well talk about, know how to address these issues. So eventually, we're looking at integrating, like one of the future goals we have is to look at integrating mental health trainings or mental into the hospital system, so that at key point, it's already known here, there are models out here, even mothers would always go for their pediatrician, take their children to the pediatrics. During those follow-up visits, we can integrate mental health care at that point in time. So that is the nutshell about Eden Foundation.
Wow, that's really amazing, and just to see how you saw a gap and you want to give back. So I don't know if you're fundraising or how people can help, because I'm sure some of those things do cost some money, or like what kind of support would you want?
Thank you. Again, as a nonprofit, support is integral to our success, right? So for now, what I believe the organization needs right now is funding opportunities and partnership opportunities, because we're looking at how to scale up and move away from, like, to able to go into other parts of Nigeria as well, and even other parts of Africa. So we're looking for like-minded organizations to partner with that share the same vision with us. There are a lot of organizations that they work around maternal health. There are organizations that provide kits for maternal health, but those kits are specific for the mothers during birth, not for preterm babies. So I haven't seen, the only next to preterm kit I have seen is one in the US here by Graham's Foundation. But again, I always say context matters. Their kit doesn't contain something like a breast pump, because in the US, it wouldn't make sense to give out a breast pump, right? Unlike because there are access to breast pumps here more than in other regions. So for us, it's more of collaborations, but international collaborations. It's very key for us how we can scale up our organizations and again fundings, because we want to, like I mentioned, we want to make sure that we are able to provide the kits to more babies, because for now we only provide kits per quarter. So we want to see how we can provide more kits to more babies, and at least if it's monthly, we'll have that. And so far, the data we've been able to extract from the mothers who have received the kits have been really positive. All the mothers so far, from the last outreach we had, all the mothers didn't have a breast pump. So all the mothers that we provided our kits to. So it was really helpful to see that we were making an impact. And we're going to go back to measure. We're going to check. We've already laid out metrics that we'll be measuring. We'll be measuring the child weight, the birth weight of the child in 3 months. We're going to measure vaccination uptake, overall health outcomes, and because the pamphlet itself comes with its own how to care for your preterm baby. So we're going to measure knowledge about how the pamphlet has been able to help them. But so far, the data we have so far has been very positive, because it shows that what we're giving out is very helpful to these families. And not just the items itself. Having a preterm baby is expensive. And in a country that has the poverty rate is really high, caring for a preterm baby can really have some financial consequences. There was a father I spoke to, he had a 31-week baby. And when I spoke with him, he said the main thing that was very helpful, the kit was very helpful, not just the items, was the fact that at that point in time, they were going through a very tough financial situation. So having that kit at that time helped them for at least the next 1 month to augment, to know that, okay, we have taken some burdens away from them, so they can focus on how to pay for the bills. So those are things. Again, I go back to system. I'm sorry, I'm debating a bit. No. There's no health insurance, right? Health insurance is a problem, so they have to pay out of pocket. So yes, for us, it's how to distribute more kits, fundings, financial support, and collaborations is something that we welcome.
Wow, that's really incredible. And I'm glad that you're making a difference in Nigeria. And we hope that you can be able to scale up. And, we're here to collaborate with you. And if people want to reach out to you, how can they be able to get in contact with you?
So would you mind, do I need to reach out to me essentially would be by email or by phone. I'm very responsive to email and I'm very responsive to phone. I'm on WhatsApp these days, so it's easier. Sometimes it's easier for me to just quickly chat. So yes, by email and via phone. And I don't know, should I call out the email address?
Yeah, go ahead. Okay. Yeah, what's your email address?
Okay, so my email address is my first name and my last name, which is Kobi, Kobi Ajayi @gmail.com. So first name, last name, Kobi Ajayi @gmail.com. I'm very responsive to my email. And if people who want to know more about the organization can go to our website, which is www.edenfoundation with a G at the end.com. That is Eden, EdenFoundationDaTiong.com. EdenFoundationG.com. Thank you.
Wow, I am so happy I got to talk to you and find out more about the work that you're doing. I'm sure this is going to be very helpful to other public health researchers, as well as students who are also interested in pursuing a PhD or in a PhD program. You have a lot on your plate, and you're doing it very well, and so I commend you for that. And thank you again for joining us, and we'll be trying to catch up with you later to see the kind of progress you've made. But I also want to thank the viewers and the listeners for their time. and to remind you to subscribe and to also reach out to Kobi if you have any questions. So thank you for joining me today and see you next time.
Thank you.